Well, thank you for that introduction. Pretty much I'm standing between you and adjournment, so hopefully you won't doze off and will be interested in what I have to say. You're not going to go to the literature and find me publishing on health literacy, but it's certainly an important area, and it's something that impacts what we do, many times in a kind of silent way, in that we don't measure it. And so it's very common for someone to say, that patient's non-compliant. And that always really kind of ticks me off, because I'm the kind of person who believes that, well, let's make sure that we're doing everything that we need to do on the physician side and on the system side and the clinic side before we start blaming the patient. And secondly, patients are times non-compliant. Health literacy can be an issue, but the pot of gold at the end of the rainbow is not that they're non-compliant. It's why. Why are they non-compliant? And thirdly, I think that when you develop a culture of blaming patients, what I've noticed about physicians is that when you blame the patient, then what happens is your brain sort of gets turned off, and you don't think about all the things that you can do and need to do. Definition by Ratson and Parker about health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information and service needed to make appropriate health decisions. Certainly knowledge is important. It's not the only thing. Sometimes people have knowledge and they don't act on it. There's still barriers, inertia. But health literacy is not exactly the same as literacy, but there are some links. If you look at some of the factors influencing health literacy, culture is one. The complexity of the information. I mean, we spend a fair amount of time in my clinic writing things out and going over things, which in and of itself can be a problem, because some people are actually not going to be able to read, even if we write things at a low level of a low grade level. We draw pictures at times, and we really work to try to, what I say, make sure the soft side of medicine is there. I'm a big believer in that, as well as knowing very much what you're doing and being very cognitively skilled and able to extract history and interpret and help people. But also, too, you've got to connect with people. So you're going to deal with, and I deal with on a regular basis, patients who have low general literacy. And the other thing that's important is that many patients already come sort of loaded for bear because they haven't had great experiences with the healthcare system. I would throw the healthcare system in with airlines and banks at times in regards to service, okay? Was at a funeral this past weekend in the Tulsa, Oklahoma area. Was supposed to have flown out of Tulsa Saturday afternoon to connect via Memphis to New York, because I had a talk at the American Society of Hypertension on Sunday morning. As it turns out, as I'm headed to the airport from Muskogee, Oklahoma, my cell phone goes off, and it's Delta Airlines saying, "Oh, we canceled your flight to Memphis, and we rebooked you in the morning at 6:10. So I had to get on the email and get a buddy of mine to actually a former University of Michigan faculty, Shauna Nesbitt, to give a talk for me the next day, and I got there for the afternoon. I think in the healthcare arena, there's a lot of moving parts, and people oftentimes aren't trained, and there's a lot of handoffs, and there's a lot of potential problems that we run into. We also run, as we have a large African American population, for sure for positive, a number of them have been treated indifferently or bad by the system. And so even when they come in and they see someone like me, they don't necessarily expect to be treated well. And my deal is I'm going to sit down and try to connect with people. That's what I try to role model. I'm going to talk to them like they have a brain. I'm going to make sure they understand they're in control. And if they don't want to do Plan A, we'll do Plan B, even if I think Plan A is the best. And I think, in a way, I kind of get people to do more of what I want them to do by basically saying, I'm not ever going to fight with you about it. So the complexity of what we do, the experiences in the healthcare system, which are very, very varied by people and class, cultural factors, as well as general literacy are important. We've got a real problem in the United States. Numbers are not so good. Got about 90 million people who don't have enough literacy proficiency to even understand and act on health information. The issue of health literacy at times is a more important predictor of health than race. And to me, that's a key point, because if you tell me that this happens in Hispanics or blacks or whatever, there's not much I can do about it unless I understand really what the modifiable factors are. So as individuals of a group, you may see that there's more problems here or more barriers there and all, but you're going to have to really get past this, the descriptive is more common in blacks or whites or whatever group, and really understand the mediators. Because if you don't understand the mediators, you can describe all you want, but you're going to have a hard time making things better. Numeracy is the ability to understand and use numbers in daily life, and clearly the level of numeracy in our society is low as well. You've got roughly 3 in 5 U.S. adults who have trouble performing just very simple quantitative skills, and roughly another 1 in 4 possess only basic quantitative skills. And you think about where our economy is going and what is needed to function, let alone navigate the healthcare system, but to be able to make a living, and this is frightening. Now, there are demographic groups that are more prone to have a low health literacy level, but remember that there's a lot of heterogeneity within those groups. And so while, yes, you're going to see that Hispanics and blacks have low literacy and health literacy levels, you're going to run into people. You can't just blanketly assume that everyone who looks like me is not going to be literate or health literate. Again, it really highlights why you need to really get level at the data at the level of the individual. And as I freely admit, we don't routinely do that in the healthcare system right now. And I'll actually offer a couple of lame excuses why we don't do it. But it's also a challenge to people who want to do research, because the stronger evidence you have, the better you're going to be able to move administrators, people like myself, hospital administrators, to change our systems and to invest in our systems to help with this. Now, numeracy has been linked to health, and it can actually be disease specific. There's a scale out there for diabetes numeracy. And it's linked to health literacy, but they don't necessarily invariably track just totally in tandem. Again, the important factor about numeracy and health literacy is that they're modifiable, and they're things that we may be able to overcome and facilitate sort of breaking that barrier down, if we communicate with people better. And all, and so to me the modifiable aspect is very, very important. Now, if you look in the U.S. population and say the percentage of levels of adults in each health literacy level, you can see that the tails, the most proficient and the below basic, are rather thin. There are a lot of people that are clearly below the proficient level, and just under 40% are below the basic, or basic or below basic. Here's data on race and ethnicity, and in general, racial and ethnic minorities have less health literacy than whites, with the exception of Asian Pacific Islanders. Asian Pacific Islanders actually are just the opposite; they have more. In the Hispanic population, for example, in the black population and the American Indian Alaskan Native, you basically have below basic skills in anywhere from 24% to 41% of those individuals. But even if you're taking care of white patients, if you make the assumption that none of them are going to have this problem, again, you're mistaken, because some will. It's just in a probabilistic sense, it's actually less. Only 2 to 4% of Black and Hispanics are at the most highest level of proficiency. And look in the far right at the population with basic and below skills, and you see that those are tens of millions of people out there. And these are individuals that we're going to try to take care of in the healthcare system, and also hopefully increasingly prevent disease and keep them healthy outside of the healthcare system. There's a funny relationship between health literacy and age. As you go from younger to the middle age, you sort of see 25 to 39, you see a steady uptick in the most proficient group, the highest level of health literacy, and then it starts back down once you start getting into the 40, 49 year age category. On the low end, interestingly, it's fairly flat until you get in the 65 plus age category. So people don't just have one of these characteristics. They may be older, they may be Black, they may be non-English speaking, et cetera, some combination of those factors. And again, that's why you're going to have to take this group data and actually try to get information at the individual level. Health literacy scores, the higher the better. You can see that the further away you get from poverty, the greater the scores are in health literacy. And I don't think there's any doubt that some of the bad health outcomes that we see linked to education and to lower levels of education and income are actually going to be mediated by poor health literacy. If you're English speaking, you have an advantage. Maybe not a huge advantage, but you do have an advantage. And if you're Spanish speaking, you're clearly down the ladder there on health literacy scores. If you're a Medicare enrollee, at least there are some data that suggests that low literacy people on Medicare are going to have more hospitalizations than those who have adequate literacy. And perhaps the most cruel disparity of all is premature mortality. And when you look at the percent alive, it tracks that the greater percentage alive, if you have adequate health literacy, marginal is intermediate, and inadequate is clearly lower. Now, disparities, it's funny, disparities became a buzzword, and I kind of look back at my career, I said, well, I probably have always been interested in disparities and doing disparities-related research, even before it became a buzzword. And there's a belief I have about disparities that it may be on a slide coming up, and that is, some people think when you talk about disparities, what you're really talking about is just the person or the people who are getting the short end of the stick. And that is a focus of disparities, but there's a much broader context to disparities than that, as I will try to convince you of.